No CEUs will be provided for this webinar. However, a certificate of attendance will be sent to all attendees following the session through your email. Also, we have attached the PowerPoints in your handouts portion of your control panel, so you can feel free to print those off as well. Now I would like to introduce our guest speaker today. Dr. Patricia Epse-Pfeifer is a neuropsychologist in the UIHC Department of Psychiatry and Pediatrics and is the director of the Child Psychology Service within the Child and Adolescent Psychiatry Clinic. She is a clinical faculty member who is also active in research in the areas of juvenile Huntington's disease, traumatic brain injury, epilepsy, and diabetes. Thank you all for participating today, and I will go ahead and let Patricia get started. Thank you, Patricia.
Good morning, and thank you for signing up for the webinar. I'm excited to talk to you today about an area that I really enjoy, pediatric neuropsych assessment, and we'll be spending the next hour talking about what that is, what role it may play in your children's mental health and neuropsychological health, as well as I'll try to answer any questions that you may have that pertain to that. So let's begin. Okay, so I have no financial disclosures to disclose. Go ahead. So the objectives for today's webinar are to identify when to consider a neuropsychological assessment for your child, learn how neuropsychological assessment may help your child and help you as a family better understand your child, and gain a better understanding of cognitive and emotional factors to consider in brain injury recovery. So to start with, since many of the families that I work with, even though they're referred from their primary care physician or their neurologist, they may not necessarily understand what they're being referred to because no one really knows what a neuropsychologist is. So a neuropsychology is a subspecialty within the field of psychology that focuses on brain behavior relationships. Clinical neuropsychology is the application of assessment and intervention principles based on the scientific study of human behavior across the lifespan as it relates to normal and abnormal functioning of the central nervous system. There are specific guidelines. Whoops. Can you go up?
Oh.
Several more.
Sorry.
So there are specific guidelines, that's okay. There are specific guidelines for specialty education and training to become a neuropsychologist. So neuropsychologists have a doctoral degree, either a PhD or a PsyD in psychology from a regionally accredited university. They obtain internship training that specializes in clinical neuropsychology from an APA, which is the American Psychological Association, or the CPA, which is the Canadian Psychological Association accredited program. And then they're required to do a 2-year residency and or fellowship specializing in clinical neuropsychology, as well as obtaining ongoing continuing education studying clinical neuropsych throughout their career. I'll have you go ahead one more. Thank you. So a neuropsychologist uses neuropsychological testing to study brain behavior relationships by using standardized assessments that look at brain functioning, that include looking at a child's attention and concentration skills, memory for information or how they encode and recall information, their abstract reasoning skills, mental flexibility or set shifting, their speeded processing of information, motor functioning that might impede visual motor coordination, handwriting, as well as sensory perceptual functions and mood and personality functioning. Most often, neuropsychological evaluations also looked at adaptive functioning, often from a parent or a teacher's perspective, as well as social emotional functioning and development. And so in essence, this is a brain and emotional functioning checkup to look at where that child's strengths and weaknesses are. So through neuropsych testing, we use individually administered measures that are standardized and look at a child's abilities in those different areas. We use their performance and norm it based on how do they perform compared to other kids that are at their age and education, as well as some of our tests, such as some of the memory tests or motor functioning, are also normed on gender as well as age. So neuropsych testing is no longer needed to localize a lesion since we have MRIs and CT scans, but it is used to help describe a child's cognitive functions, which may not always match different structures that are found on neuroimaging. So we oftentimes work with neurologists or neurosurgeons when someone has a brain tumor, has epilepsy or seizures that are difficult to treat or require surgical interventions. And our testing is used to look at brain functioning to see if it correlates with the CT or MRI scans and findings, but sometimes those do not match up. If you think about all the information about sports-related concussions, most of the time those mild concussions do not show any evidence of difficulties on MRI or CT scans that are done in the emergency room. But most often those kids right away are having a really challenging time as they're doing that initial recovery. So again, some of the findings have no functional evidence. But we use the neuropsych testing to help monitor for changes and improvements or decline over time, depending on what each individual child's circumstances are. So with neuropsych testing, we look at a child's level of performance. How well does the patient do in certain areas? Are there areas of specific deficit? Are there patterns of deficits and relationships among test scores that would show some specific areas of neurocognitive impairment? And we also look for lateralization of different functions of the brain. So on a practical level, as a neuropsychologist, I use this information to link behaviors that are seen by teachers and parents to deficits that may be seen on the testing to help me make recommendations to help that child improve their functioning across home and school and within the community. I also heavily rely on a child's areas of cognitive and emotional strength and coping skills to help them compensate for any weaknesses that I might identify through the testing. I view those strengths as equally as important as any weaknesses or deficits that I find, because the goal when a parent brings their child to me, the goal is to help figure out what is the best way to help them improve their functioning in whatever areas are most problematic. I do that by integrating information from the parent and caretaker, the patient's perspective. It's also important to get the child's perception of where they're struggling, as well as history of previous attempts to cope. Have they had previous difficulties that might slow down recovery after a head trauma? And what other factors might contribute to kind of their difficulties functioning now, whether it's pain-related issues, poor sleep, are there peer issues that are getting in the way, or anxiety and depression? So again, we use these assessments to try to compare a child's performance from one time to the next and guide those treatment recommendations. You can go ahead and click ahead, please.
Okay. Is this the right slide?
There we go. So when should you consider a neuropsychological Yep, that's the right slide. Thank you. When should you consider a neuropsychological assessment? Most often your physician, whether it's a primary care physician, a neurologist, a psychiatrist, may recommend that your child have a neuropsych assessment, and this could be for a number of reasons. Most often from your physician's perspective, it's to help assist in establishing a diagnosis or rule out cognitive factors that might be slowing down recovery or treatment efforts. And they try to use that baseline testing to document your child's current skill set to help plan a medical intervention, whether it's a change in medications, surgical treatment, treatment for cancer, and after that medical intervention to help further monitor for changes in cognitive skills and abilities. It's also used to document your child's development over time, since your child's brain is still developing. So there's still really a moving target when it comes to that neurocognitive development, regardless of what type of injury or difficulty that they're having. And it also helps to families to better understand what that child's expectations might be. So there are a large range of conditions that I see patients for neuropsych assessment. Those could be hydrocephalus, cerebral palsy, any type of seizure disorder, neurofibromatosis, brain tumors. Most often I see patients that have had some sort of brain injury or insult, whether it's an accident, a stroke, or an infection of the brain. Other medical problems that could place your child at increased risk would be poorly controlled diabetes, chronic heart or respiratory problems, certain genetic disorders such as Huntington's disease or juvenile onset, and treatment for childhood cancer. I often also see children that there is documented or suspected in utero drug exposure that may help explain why treatment interventions such as medications and behavior supports haven't been as successful, as well as events where carbon monoxide poisoning has taken place, or children or adolescents have engaged in huffing or other type of polysubstance use. Here in the child psychiatry department, I also am often referred patients that have neurodevelopmental disorders such as tic disorders or Tourette's disorder, autism spectrum disorder patients, as well as those with suspected learning disabilities or ADHD versus mood disorders. So how will neuropsych assessment help your child and help you as a family? That's one of the questions that I most often asked, and I try to gear my neuropsych assessments to best help the individual that I'm seeing. And so the role of a neuropsychologist is really to look at that evaluation as a way to establish a baseline or a profile of your child's cognitive strengths and weaknesses across multiple domains of functioning. Again, that attention, memory, executive dysfunction areas, to help me arrive at a neurobehavioral diagnosis and likely explanation for chief complaints. Also to assist in developing a comprehensive and individualized treatment plan, which may include ruling out or ruling in different type of emotional difficulties that often arise in these situations. This is important because oftentimes deficits that are identified can be associated with different treatment outcomes. And being able to recommend individually tailored ways to overcome those weaknesses may help lead to increased psychological well-being, better functioning, and efficient learning of new information, and just overall better functioning in a child's job, which is most often school. When I approach a neuropsych evaluation, there are multiple information needs. There's often the physician who made the referral, who is going to ask what is the impact of this disorder or treatment, or what is the diagnostic clarification. For the parent, it's most often questions such as what's fair to expect Am I being too hard on my child? What are they capable of? For the child, it's often helping them better understand what's happening to them, trying to normalize some of their difficulties that they're having, or provide reassurance when they may feel like they're failing at everything, but in actuality, they really do have a lot of areas of strength that they may not focus on, as well as school personnel better understanding what they're dealing with and what type of interventions might be appropriate for the school to initiate because of that child's area of deficit. There are a number of cognitive and emotional factors that are important for the psychologist to consider. So in general, if we just look at brain injury, there is an estimated 1.7 million people who sustain a traumatic brain injury annually in the United States alone. TBI is a contributing factor to at least a third of all injury-related deaths in the U.S., and that's across child and adult. And approximately 75% or 3/4 of TBIs that occur each year are concussions or other forms of mild TBI. Can you click it? Oh, thank you. So children aged 0 to 4, as well as older adolescents from ages 15 to 19, and adults age 65 and above are most likely to sustain a TBI. Among children in that first age group, the 0 to 14 years, TBI often results in an estimated 2,000 plus deaths a year, 35,000 hospitalization, as well as almost 500,000 emergency department visits. And that's just from data from the CDC in 2010. So that's one of the reasons why children and young adults, we consider TBI to be a primary cause of long-term disability. So when we look at TBI by gender, in every age group, those rates are higher in males than females. Many males from birth to age 4 have the highest rates of TBI-related emergency department visits. And studies have showed poorer outcomes for females on many of the variables in studies that have been looked at thus far. And the likelihood of poorer outcomes is 1.5 times higher for females than males. In the research literature, we're really trying to figure out why those gender differences are occurring. And one thing to think about is that most of the research in TBI, as with many different areas of difficulty and medical complications, is done in adult populations. So there's really a lot of room for research in child populations to help sort out what some of these variables are. And this slide just helps to reinforce the higher rate of injuries in males than females. So with neuropsych assessment and working with children, one of the things that we look at in the assessment and management of pediatric brain injuries, and in dealing with any child patient that I work with, is to look at development and change-related concerns. So I'm trained in both adult and child, and when I came to the University of Iowa, I chose to work predominantly with children and young adults. And part of that is I viewed it as more of a challenge to work with children because developmentally they're still this moving target. And so the challenge in working with kids is understanding what's normal in relation to that continued development that their brain is going through, as well as figuring out how to best understand a child and appreciate any deviations they may have cognitively and behaviorally within that development, as well as ways to better evaluate and treat children to understand when real change has occurred versus when is it more motivational factors or when are emotional factors such as frustration, quickness to anger, anxiety, worry, or depression, when are those types of factors really impeding their functioning as opposed to true neurocognitive damage taking place. So key issues to consider are that in moderate to severe TBI, when that is sustained in infancy or early childhood, it's most often associated with greater or more persistent deficits. Oftentimes, this is because it's happening during really important times of development where acquisition of skills, whether it's walking or speech or other motor issues, are developing. We're also looking at TBI in general may have more significant long-term effects for children that may have been previously recognized, especially in kids that have more of the mild TBI or concussions that don't resolve as quickly. And younger kids may demonstrate a slower rate of learning over time. So instead of showing a decline in functioning, they may be instead demonstrating just slower acquisition of learning over time. And so they may look as if they're falling further and further behind. And so the goal is really to look at what is the effect on that child's emerging skills, which is, I think, more challenging to do than looking at what has been the impact on an adult's already established skills. There are also a number of developmental differences in that the context of the child is very different from that of working with an adult. They are learning and managing the demands of multiple things, such as their family, school environment, the community, social interactions, and so their kind of designated job is very different from an adult who may also suffer or experience a TBI. So the child's job is very much learning and acquiring knowledge from their environment, focusing on their academics and learning, learning to communicate, relate socially, use appropriate reciprocal social skills. How do they kind of modulate their emotions, or how can they react to different situations emotionally? And that can be quite a challenge for teenagers, particularly teenagers that are dealing with the result of a TBI or any type of neurodevelopmental difficulty, as well as learning just kind of simple behavioral self-control and how to best self-monitor and manage their environment and their surroundings. And then we're also looking at the role that kind of they're learning different independent skills, and that's where the executive functioning factors come in, because they're really having to develop those cognitive, behavioral, and emotional self-control that can be challenging for any adolescent or child, let alone someone that has experienced loss or difficulties related to a head trauma. When we look at just the emotional factors related to TBI, multiple symptoms are seen after a head injury and are quite common. Depression, anxiety, increased aggression, psychosis, delirium, memory and personality disturbances, increased rate of substance abuse, and high rates of sleep disturbance are all different symptoms that can arise after a head trauma.
Patricia, are you there?
Yep, I'm here.
We have a question.
Okay.
From Carrie, how long after a concussion would you recommend referring a youth for comprehensive neuropsych testing if they are still having challenges?
So I work with our inpatient trauma unit as well as with sports medicine. So one of my areas of specialty is sports concussion, and this is a question that comes up pretty frequently. Most concussions will resolve within 2 to 3 weeks. So getting testing right away is likely going to show some areas of deficit, because anyone that's having headache pain or light sensitivities, just is not feeling well after a concussion, is going to show changes in attention and potentially memory and processing speed on our neurocognitive tests. So typically I would recommend that you wait those 2 to 3 weeks and see how your child is functioning. If you're noticing that your child is still struggling to the point where they can't go to school, or they're just really not feeling well, then I would communicate with your primary care physician and discuss whether neuropsych testing would be indicated. Now, the kids that I see, since I see kids that aren't recovering, I rarely see those that are in that kind of first month recovery period. Instead, I'm seeing those that are 2, 3, sometimes 9 months out.
Well, awesome. Thank you very much. That's the only question we have for now, so I'll go ahead and let you continue.
Okay. So just to give you an idea about these different emotional symptoms and cognitive symptoms that can arise. Symptoms, if we look at symptoms of post-concussion syndrome, in one study, poor concentration was endorsed by 71% of the patients, irritability in 66% of the patients, fatigue in 64% of the patients, depression in 63%. So those are pretty high levels that are considered common in those first few weeks after sustaining a head trauma. And so when we look at the kind of the role of emotional symptoms that can arise in any of these neurocognitive issues, we really want to look at, are these factors that are present, because these are the types of symptoms that we really need to monitor, because they have the potential to really slow down recovery if interventions aren't put into place. So when we look at depression, again, that's fairly common after a TBI. And even, one study showed that 33% of the study participants developed major depression 1 year post-TBI. So even 12 months out, they were reporting significant levels of depression symptoms. That same study showed comorbid anxiety and increased aggression issues. And so those are really areas that I feel treatment providers need to keep a close eye on, because those are very treatable things, and they don't necessarily need to be treated with medications. As a psychologist and neuropsychologist, I don't prescribe medications, but I work in psychiatry, so I work hand in hand with my psychiatry colleagues, and many of them would even say that, trying supportive therapy supports, behavioral supports first can really benefit a child that's recovering from a TBI. Now, many times we also need to look at, does this child have pre-existing history of mood dysregulation? And if so, they would be considered at risk of having an exacerbation or an increase in those symptoms post-injury. If you can go to the next slide, please. And again, with anxiety, very common. One study showed a prevalence as high as 70%. This can include generalized anxiety disorder, persistent worry, tension, and fearfulness. And most often in kids that I work with, I see kind of these increases in anxiety and worry and kind of poor coping strategies, because if they're an active child that's had a head trauma, they're now at a point where they're not allowed to engage in those kind of different activities until their recovery has taken place. And so if you have someone where their coping mechanism was to go out and do a sport, to go outside and go biking or rollerblading or roller skating, skateboarding, and they're not allowed to engage in those activities, and they don't have other coping strategies that they readily use, then they're going to be at a place where they just don't know what to do. And so those are often the kids that I see that are having a really hard time because they just can't do what they used to do to cope. Aggression is also one of the main reasons for referral that I see a child. And aggression can be verbal aggression. It can be physical aggression, but most often it's parents reporting that their child kind of has a short fuse, overreacts to things where they may not have before, really just not editing what they say before they say it. And so this is often a change that parents notice and that's most disruptive because they don't want, they see their child that's never had an issue in this area now reacting this way, and that kind of sets off an alarm. And when we look at aggression, we also have to look at that executive functioning component. If they're not able to kind of self-monitor how they react to things, that can also be linked to different impairments depending on where the kind of location in the brain, if there was more of a localized injury or not. Now, luckily, psychotic symptoms are pretty rare. And this information that's on this slide is also adult-focused. Most of the time, psychotic symptoms or delirium are seen when a child is inpatient right after the trauma, and most often it's because of medication effects from the pain meds that they're on. So I have not seen a child that has dealt with primarily psychosis outside of that delirium from medication-induced behaviors. Now, memory disturbances are pretty frequent, occur in about 80% of individuals that have had a significant TBI. Some of the memory difficulties that I most often run into are secondary to poor attention and focus abilities. If you're not sleeping well, if your mood is off and you're kind of overreactive, or if you're having any pain-related issues such as headaches, if you've had, broken bones that are still healing, if you're just kind of beaten up from your accident, then all of those factors are going to get in the way of your ability to focus. If you think about when you have a headache, how well are you able to focus on someone talking to you versus when you don't have that headache? Or if you haven't slept well for several days, how well are you able to focus on people talking to you and information coming in? I know for myself, that's more challenging. And so a person that is dealing with these different issues can really have poor concentration and really attribute that to having difficulties with memory, when in fact it's most often related just to attention being off. And so our memory testing and attention testing that we do can help to look at how well a child encodes that information. Are they able to give that information out after 30 minutes or when using different type of recognition formats? And then parents are also often interested in personality changes because of the aggression, the mood lability, apathy, or just a child being more disinhibited. And most of the time, severe head traumas may show prefrontal or orbital regions of the brain that have been impacted that might contribute to some of these changes in personality. It can also be related to changes in neurotransmitters in the brain. Oftentimes, it's kind of a combination of events and mood factors.
And Patricia, we have another
Mhm.
question. This one is
Sure.
from, I'm not very quite sure how to pronounce your name, but what are some therapies or fixes for aggression for children living with TBI?
So the type of therapy, I mean, it's going to depend on the age of the child. Younger kids, if you're working with a 3 or 4-year-old, it's going to be much different than working with a child that's in elementary school or an adolescent that's in junior high or high school. Now, for many of the kind of older elementary school kids or junior high and high school kids, I would often recommend kind of behavioral supports as well as cognitive behavioral therapy. Oftentimes, a lot of those behaviors can also be from, having difficulties regulating how they react. And so here we have a program where we do dialectical behavior therapy with kids that are in 7th grade to 12th grade to help them learn ways to cope with their strong emotions. And so those are the types of interventions that we most often use here. And I oftentimes have kids that have been on our surgical trauma unit for a head injury. If they're local or within driving distance, those kids can also come to our group, and we have like 8-week sessions where we work with that group of adolescents on learning better mood regulation.
All right, well, thank you. That's all we have for now, so I'll let you go ahead and
Okay.
continue.
All right. Can you forward it one more? So again, to go back to, what can a parent and child gain or a family gain from having a neuropsych evaluation? We really try to focus on educating the patients and their caregivers about their strengths and weaknesses, recommend individually tailored ways to overcome those weaknesses that in essence may lead to increased psychological well-being and kind of more appropriate functioning across settings, as well as normalize their experience of difficulties. As with many kids, or even as adults, when they have this type of injury that's occurred or they have a diagnosis that sets them apart from their peers and friends, oftentimes they just feel like they're all alone and that no one else is dealing with the same type of thing. And so helping that child to understand that, they really do have areas of strength. Many of the feelings and emotions they're having are normal given the circumstances, and that to really emphasize that they're not going crazy, even though they may feel like they are and spiraling out of control. So, we do have a research program that I'm involved with here at the university that also includes Blank Children's Hospital, as well as a children's hospital in Minneapolis and, excuse me, one in Kansas City that looks at kind of helping parents support their children after a traumatic brain injury. Two of my colleagues, Dr. Marizan Ramirez and Lisa Roth from our public health kind of clinic or kind of the College of Public Health, they started this research study to look at kind of what are some things that can help parents get the resources they need excuse me, to bring as they're bringing their child home or transitioning them home from the hospital. Can you click ahead one, please? So this research study was brought about because they were getting a lot of feedback from trauma nurses and parents and other hospital providers that, these kids that came in were stabilized medically, were being sent home, and really not much information was provided to families about the risk for post-traumatic stress disorders, difficulties with mood, and kind of what, excuse me, what other supports could be made available to help that transition and recovery period be better regulated. So because the university sees such a high rate of the TBIs and injuries that come in through the state, we really looked at kind of what were the ways that we could help better prepare parents to help their child psychologically. And what is a way that we can help them kind of intervene before decline in school performance or depression, anxiety, social isolation, those types of things take over. Can you click ahead, please? So again, part of the reason we are starting to research this is that, pain control, ability to walk and get around their house, what home care equipment do they need, are there child passenger safety things in place like car seats, but no one was talking about the psychological concerns. And so parents were often caught unprepared that their child was reacting in the way that they were reacting. And so then they were thinking that, oh my goodness, what's happened? Is my child going to be okay? Not being adequately prepared that these can be some common things that can happen. And here are the signs and symptoms to look for so that a parent can then request some intervention early on before it gets out of control. So some of the things that we were hearing is that, from one pediatric healthcare provider, one of the nurses, they saw that kids were quite stressed, they were frightened. A mother of a 13-year-old boy said he was very angry that he couldn't do the things he wanted to do. He was very frustrated. Another mother of a 16-year-old girl mentioned that she felt her child felt isolated from her friends. And so that withdrawal and isolation can then add even more to how they're feeling psychologically. And so this study looks at what we can do and how we can help get better understanding and better interventions in place for that psychological functioning. So we have a program that's called Listen, Protect, Connect for injured kids, and it's helping parents to help their children during times of stress. And so it uses motivational interviewing strategies to help a parent talk to their kid about how they're feeling emotionally and help them to listen and not necessarily change how they talk to their child, but just help them to reinforce that these are all normal feelings to have and that it's okay to seek help if those feelings get out of control. And so one of the aims of the study is to look at the effectiveness in improving symptom of stress, coping, family support, and quality of life in the child and the parents after a child sustains that TBI. And so we are in the data collection stages and we're about halfway to collecting about 300 participants between the ages of 10 to 17. And all of these children were hospitalized into one of Iowa's 2 children's hospitals, as well as the one in Kansas City and Minneapolis. And we conduct baseline, 6-week, 3-month, and 6-month assessments of PTSD and mood symptoms, as well as coping strategies, providing family support, and assessments of quality of life post-injury. I know that was a lot of information. Does anyone have any questions?
We do have another question from Autumn. How do you distinguish the difference between medication side effects and actual psychological symptoms following a brain tumor, for instance, removal with associated seizure activity?
So so is the question, how do I associate or how do I differentiate side effects from medication if someone's had a tumor removal that's also on seizure meds?
Yes. So, for example, if someone had a brain tumor removal who also had seizure activity, how would you know the difference between those medication side effects? I'm guessing that's what she meant by that.
Okay, so that's a good question. I mean, one thing that we look at when I work with kids that have seizure disorders or brain tumors is that oftentimes a child with a brain tumor or had that brain tumor removal will be put on seizure medications prophylactically to help reduce the chances of them having seizures. In some cases, they have both. With many of the seizure meds, if not all, there are potential side effects, as with most medications. Most often, those are kind of psychomotor slowing, difficulties with fatigue, and so have to really take a good history to look at, are there fluctuations in when that child's fatigue level is greatest? Does their testing results, do those correlate with other areas of deficit? And so sometimes it can be really challenging to tease out what's medication and what isn't. With seizures, I would never have a patient come in and not be on their seizure meds. So we have to just take a pretty broad look at a number of factors to help me come to my conclusions.
Thank you. And then we have another question. Would you be willing to share your contact information for more detailed questions by chance?
Sure. So most often, you can look up on the University of Iowa Hospital and Clinic's website under the Department of Psychiatry, and my contact information should be listed there under faculty. I also can provide my direct office number. And I don't know, Annie, would it be best for me just to send that to you and you can disseminate, or?
Yes, we can do it that way. So go ahead and
Okay.
me, and then I will make sure to email that out to all of the attendees following the session today.
Yeah. Right now, our hospital system is going through some changes with our call center, kind of a localized call center in the hospital. And so it's my understanding that sometimes it can be challenging to, when you call in, to talk to a specific provider. And so I often just give my direct clinic number and let parents know that if they do call, just leave a message, because if I don't answer, I'm most likely testing. And since my appointments last anywhere from 4 to 6 hours, I usually do those in the morning, so afternoons would be when I would return calls.
All right, thank you. Yeah, I'll be sure to send that out to everyone following the session today. And then another question is from a contact we have at the Brain Injury Alliance of Washington, wondering if that training manual you mentioned for Learn, Protect, Correct, if that's available for them to use as a resource for their pediatric clients.
So I will have to discuss that with my research colleagues. Since I'm on the grant, but I didn't come up with that Learn, Protect, Connect, I don't have permission to give that out, but I can ask and see if it could be made available.
All right, thank you so much.
Yeah.
While we are waiting for any more questions to come in, I just wanted to remind everyone to please feel free to reach out to us as the Brain Injury Alliance of Iowa if you are ever in need of any brain injury resources or information. Our Neuro Resource Facilitation Program is designed to help connect individuals with brain injury along with their loved ones and the professionals that are serving them to any needed supports and services in the community. We are always available to provide case consults to professionals. If you have a client with a brain injury and you're looking for resources or support, and figuring out where to go or what to do. We are also available to provide general training on brain injury. In our neuro resource facilitation program, staff members would be the one to do that. So I will see if there's any more questions. It doesn't look like we have any more at this time. So Patricia, do you have anything you want to say to wrap up?
I just want to say thank you for taking the time to listen today. Working with kids and adults with brain injury is really one of the areas that I truly enjoy, mainly because my interest in neuropsych came about from having a cousin who sustained a severe TBI as I was a child. So having a family member that went through this and watching my family and his family kind of figure out what to do was challenging. And so, my hope is that if there is more information about what is available for treatment and assessment interventions, that families won't have to feel quite as alone.
Well, thank you again for presenting today, Patricia. I really appreciate it. And just as a reminder, this webinar was recorded, and it will be saved on our website at biaia.org in the coming days, along with our YouTube page. And your certificate of attendance will be emailed out to you along with a link for the survey for your feedback on the webinar today. So thank you again, Patricia, for being with us, and thank you everyone for attending, and I hope you all have a good rest of your day. Thank you.
Thank you.
Bye, Patricia.
Bye.